Good evening, one and all, to this platform of Tuesday Take Part 3. This is the third part, which is done by the Women's Committee MahaIP in association with Maharashtra IIP. The program today is based on theme based, and it is the infectious disease spectrum. I would like to welcome on behalf of Women's Committee and MahaIP all the respected seniors, Dr. Bodhankar sir, and all our senior colleagues, teachers, respected friends, and our speakers of today, as well as the judges. And I would now like to tell you in a few words about this program. This program has been started as for to reach the unreached, that is our pediatricians of periphery of the districts or the city branches, where we give them a part for this program, and every time a new district is taken up from the zonal wise and another member is given a chance for this platform, as everyone don't get chance in our state or regional conferences. So that is the basic for this program, and this is the successful second part we have completed, and this is the third one. As we know that the study of pediatric infectious diseases has been a challenging and ever changing for all of us professionals to gather information with the history and physical examination that we know, and to place this into the context of relevant epidemiology and incubation period, and then to select a few appropriate diagnostic studies is still exciting for us all. Putting these many pieces together and arriving at the correct diagnosis is akin to solving a crime like Sherlock Holmes do. On many occasions, just seeing the clue, a characteristic rash, an asymmetry, a swelling, it will solve the medical puzzle, lead to the recovery with proper management of the patient, and bring us the satisfaction, and which is nothing comparable to any other thing. And one should realize that there is no alternative to proper history taking in routine office practice, and relevant history and thorough physical examination form the base of probable diagnosis. So, dear friends, welcome you all to this infectious disease spectrum. In the next 1 hour or so, we will be continuing with our 6 speakers, and there are 2 judges who will be guiding them. First, I would like to welcome Dr. Gangolia sir, our MahaIP president, and invite him to guide us for this talk.
Good evening and namaste, respected MMC observers, experts Joydeep sir and Pramod sir, all 6 speakers, office bearers of MahaIP, MahaIP Women Committee, dignitaries on the Zoom dais, as well as I acknowledge the presence of Dr. Uday Bodhankar sir and attendees of this third episode of Tuesday Takes. Basically a concept of Dr. N.K. Subbu sir, which was a talk of 4 minutes and 20 speakers. But we have given discount of 1 more minute, so 5 minutes to this episode, and that is a Mudde Ki Baat on a topic which is useful to in our day-to-day practice with clear-cut, take-home practical message is the idea of this program. Fever, investigations, and antibiotics are the elements of this today's session of the point of discussions. And we are very fortunate to have a pioneer infectious disease specialist, Dr. Joydeep sir, as well as our own colleague, Dr. Pramod sir, EBCIP of Central Indian Academy of Pediatrics from Pune. Thank you for your valuable time, both experts to be with us, and hearty congratulations to MahaIP Women Committee, Renu, Sonali, and all their team to do these wonderful sessions. These are third episodes and they are doing the very great work. Hats off to you, MahaIP Women Committee, and I'm sure that this session will be also a successful one. All my best wishes. Thank you very much.
Thank you so much, Hemant Gangolia ji sir, for your kind words. Now I request Dr. Amol Pawar, who is the Secretary General of Maharashtra IIP, to give his valuable inputs.
Thank you, Renu ma'am. Good evening, today's experts, Dr. Jaideep Chaudhary, Dr. Pramod Kulkarni sir, then President MahaIP, Dr. Hemant Gangolia sir, then our patron, Maharashtra IIP patron, Dr. Bodhankar sir. I welcome today's MMC observers, Dr. Sanjay Iyer sir, Senior Neonatologist from Nasik, and Dr. Mewash Sahil Sheikh, from pediatrician from Ahmednagar, for their valuable presence in audience in today's session. At the outset, I thank Renu ma'am and Dr. Chairperson, Women's Committee, and Dr. Sonali Shirpate ma'am, Co-Chairperson, Maharashtra IIP Women Committee, and all the zonal EB members for this coordinating speakers for today's session. From MahaIP, I assure all the delegates a very good science and inputs which will help you all in day-to-day practice. Over to you, Renu ma'am.
Thank you so much. As we know that this has been granted 2 MMC points for this program, I would like to request all the delegates that they should write their name. Then later on, they should write the CIAP number. Along with that, the MMC number in that order. And so that you will be getting, and you should also attend the whole session, which is recorded. So please be with us for the next 1 hour or so. So today with me, another moderator is Dr. Pratibha Patil ma'am, who is pediatric pulmonologist from
Dr.
Solapur.
Dr. Renu madam, we will just have a word from our patron, Dr. Uday Bodhankar.
Yes, sir. Yes, sir. I was going to him only. I request Dr. Bodhankar sir to please unmute and unmute his video also. Sir, please, we will like to have your expert comments and your valuable input, sir.
Thank you, Dr. Renu. Thank you, Dr. Hemant, Dr. Pawar, Dr. Jaideep, Dr. Patil, and all respected faculty. I don't think I should be spending a time between you and the expert faculty, but I must compliment Hemant and Pawar's initiative of MahaIP of continuing medical education in last. This is the 3rd time. I could not attend to a talk of the town and talk of the state, but I compliment Hemant, Renu, and Pawar for taking initiative in sensitizing the practicing pediatrician on very common topic, infectious disease. Of it, Dr. Jaideep, Dr. Kulkarni, they are the expert. I wish the MahaIP great success. I will not take much time. All the best for faculty, and let us have academic fees. Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, Bodhankar sir. It was very much nice of you to say such kind words. And also, one of the thing I would like to say is that those who are there on the YouTube platform, please write down the same thing on the YouTube chat. And your question and answers can be also put in the chat box at the end of the session. Now I would like to introduce today's judges. For this, both are the infectious disease experts from India. First one is Dr. Jaideep Chaudhary. He is Professor, Department of Pediatrics, Institute of Child Health, Kolkata, Vice President, East Zone Central IIP 2019, Chairperson IIP ID Chapter 2020, and Chairperson IIP GDBP Chapter 2022-23. Welcome to you, sir. And the next one, our own Dr. Pramod Kulkarni sir. He is present currently EB CIAP 2022 and also consultant pediatric infectious diseases practicing KM Hospital Research Center, Dinanath Mangeshkar Hospital, and also Unique Hospital at Pune. His area of interest are pediatric infectious diseases, clinical pediatrics, pediatric education, rational and quality practice. He had held many positions, especially Secretary of the India IIP Pune 2021, member West Zone National Executive Board IIP Infectious Disease Chapter 2019-2021, and presently, as I have told you, he is CIIP Executive Board 2022. He has many books to his publications, and also he is IIP module CEPID, LEID, RTI GEM convener. So, sir, thank you. Welcome all of you to this program. And now we will go over to the program. Now the first speaker who is in the line, I would like to ask Dr. Jayashree Deshpande, madam. She is a senior pediatrician from Vasai. Madam, do you want to share the slide, or do you need Pallavi ma'am to do it?
Yeah, I would like to share the slide, yeah.
Yeah, kindly do so.
Good evening, everybody. Respected Dr. Bodhankar sir, Dr. Jaideep Chaudhary sir, Dr. Pramod Kulkarni sir, Dr. Hemant Ganguly, and Dr. Amol Pawar, Dr. Renu Boralkar madam, and thank you at the outset for giving such a good opportunity to me. I'm talking on basics of fever. I'm Dr. Jayashree. Fever is an abnormal elevation temperature that occurs as part of specific biologic response that is mediated and controlled by CNS. In other words, like fever is mere oversimplification as a complex adaptive response of the host to various challenges, either infectious or non-infectious. I will, hello.
Dr. Jayashree,
will
madam, your
actu-
voice is cracking. If you can, off the video
I'll stop
and just keep
now.
audio on. Voice is
Okay.
cracking.
So fever as such, yeah, now it's okay. Hello.
Yes, yes, yes.
Yeah, so fever is an increase in body temperature of more than 2 standard deviation over the baseline. Factors, because baseline depends on the environmental factor, biological age, diurnal variation, hormones, and exercise. Infectious disease module of America gives specific sites for the measurement of temperature. Oral temperature is usually difficult in children. If it is usually 1 degree Fahrenheit lower than the core temperature. Auxiliary is the commonest mode, but it is inaccurate, not that accurate. Rectal temperature is the most near to core temperature. It is usually 100.4. After post-COVID era, like infrared thermometry and tympanic thermometer is coming into the hello. So normal
yes, madam,
body
carry on.
temperature, yeah. Normal body temperature in infants is usually higher because of increased surface area to body weight ratio. And it is because of the higher metabolic rate. To understand the temperature, we have to understand the thermoregulation because body temperature is regulated within a fairly constant range called as thermal set point, and it is the preoptic area of the anterior hypothalamus, which has warm sensitive and cold sensitive neurons. Also, the thermal balance point is the balance between pyrogens and the cryogens. Fever, there are 2 fever pathways, humoral pathway, which is through pyrogenic cytokines and circulatory pathogen associated molecular patterns or the PAMs. And the another is neural pathways, cutaneous sensory nerves gives input, and also the hepatic branch of vagus nerve is involved. Coming to the pathophysiology of fever, when infection occurs, the LPS, that is leucopolysaccharides, which are present in the cell wall of a organism, stimulates or activates the monocytes, which releases IL-1, IL-6, and tissue necrotizing factor. Tissue necrotizing factors and all actually stimulates prostaglandin production, specifically PGE2. Both the set point is elevated. Now the peripheral heat responses changes by it increases the conservation and also increases the heat production, which leads to fever. There are potential benefits of fever like retardation of growth and reproduction of bacteria and viruses, because there was it also because of this, there was a trial given as a cycles of fever in COVID infection. Also, it enhances the immune function. However, it is detrimental for a child with compromised CVS and respiratory capacity. Because it increases the BMR, increases the heart rate, oxygen consumption, and also CO2 production. What about hyperthermia, as it is life-threatening because it is not same as fever, and it is because of the felt thermoregulation. Here the set point is not changed. So for every fever, we should take history of heat exposure or use of any drugs like anticonvulsants or antidepressants. Here we should not give antipyretics, and treatment is usually cool immersion, gastric lavage, or even hemodialysis. Now we understood that fever is not an illness, but a physiological response. So we should find out the cause by history taking, examination, and investigations according to the age of the child and signs and symptoms. What about antipyretics is usually is to make the febrile child more comfortable, and routine use of normal antipyretics is not indicated in normal child. Decision should be taken on case by case basis, and aspirin has to be avoided because the risk of Ray's syndrome. Commonly used antipyretic is acetaminophen because it is time tested. It is usually given in a dose of 10 milligram per kg per dose every 4 to 6 hours. We should not give loading dose, or we should avoid combinations. Another drug which is indicated if the fever is high, it is 10 ibuprofen. We have to give 10 milligram per kg per dose every 6 hourly. This ibuprofen has a quick and long duration of action, and it should be given to the child more than 6 months of age only. Usually it has associated anti-inflammatory action, so we should give this ibuprofen to the child with juvenile arthritis with fever. There is American Association of Pediatrics gives some parental guidelines to the patient who received this antipyretics like ibuprofen or acetaminophen, because it is an OTC product. So every child who received antipyretics, we have to monitor urine output and temperature monitoring also. Also, we should give extra fluid. A word about tepid sponging. Tepid sponging is should be done with comfortable temperature of water, not with very cold, because it increases the it decreases the comfort level of the child. Usually it is indicated if there is uncertainty of the cause of the fever, or if there is any underlying neurological disorder where the thermal set point is disturbed. A baby less than 3 months or a child with underlying medical conditions, we should always be alert. Or if patient who has got fever beyond 4 to 5 days, or there is marked increase in height of fever during the course of illness, also there is a development of new localizing symptoms when we are treating this child. We should ask the parents to seek immediate medical help if the child has difficulty in breathing, not accepting feed, excessive cry, altered consciousness, or if the child has toxic look, low urine output, or if the child is the child has excessive somnolence also. Thank you.
Thank you, Dr. Jayashree ma'am, for the basics of fever. Now I request our judge, Dr. Jaideep Chaudhary sir, to please have a word or two of whatever your comments, expert comments, or you can ask questions to the speaker.
Thank you,
sir.
Dr. Renu, for the kind introduction and the forum also. It's my pleasure to be with you all. Now, as very nicely explained by Dr. Jayashree, that fever actually is our friend and not a foe. Parents often consider fever to be a foe and they are scared of fever, but as physicians, it's our duty to explain to them that at least if the child develops fever to some due to some insult, then we know the child's immune system is functioning, and then we can progress further. Second thing, that we should always discourage oral recording of temperature in children for obvious reason. Well, axillary or groin temperature measurement is acceptable because rectal temperature is practically not feasible in day-to-day practice. But what's more important is the documentation of fever. Parents should be encouraged and should be told to document the fever, time-wise chart with at what time they have given paracetamol, if they keep a record. Then when they come for follow-up to us, at least we can assess that whether the fever is increasing, decreasing, or how the fever is responding to paracetamol. So documentation is most important. Just that the body felt warm on touching doesn't make any sense. So the temperature has to be mentioned and documented. And again, the parents have to be told that paracetamol should be given only if the child is in discomfort. If the child is happy with 100 degree Fahrenheit temperature, then there is no need for antipyretics. And as Dr. Jayashree has told, I would like to again stress that if paracetamol is given at 10 milligram per kg, then 4 hourly it can be given. If it's 15 milligram per kg, then 6 hourly. This dose is safe, but definitely there is no role of combination antipyretic for management of fever. And of course, hyperthermia, in cases of hyperthermia, antipyretics is of no use, where we have to consider the environmental modification to bring down the temperature. Often there is a notion that whenever there is a fever, to bring down the temperature, we must go for cold sponging. Now, cold sponging actually causes vasoconstriction. So that again doesn't help in decreasing fever. So tepid sponging is ideal. Well, mefenamic acid actually for control of fever, the recommended and ideal are number 1 is paracetamol, and number 2 ibuprofen may be given at some places. As we have told repeatedly, combination is not at all recommended. Mefenamic acid, yes, it has some antipyretic action, of course, but mefenamic acid has more of anti-inflammatory action. For fever management, paracetamol or ibuprofen are ideal. Mefenamic acid ideally should not be used for fever management. I think there is not much more to add. Now, regarding the pattern of fever, previously there was a lot of stress given to the pattern of fever, whether it's tertiary, quotidian, or the biphasic. But with the changing pattern of infectious diseases, probably this particular patterns of fever doesn't have much significance. Nowadays, we do not see the typical saddleback fever in dengue like that. So we have to be very particular about recording and documenting the temperature rather than coming to any conclusion from the pattern of fever. So thank you. Thanks again.
Thank you, Jaideep sir, for your expert comments. Now we will proceed to our second topic today. It is an approach to short febrile illness. The presenter is Dr. Deepika Bhosle. She is pediatrician and neonatologist from Latur. So, ma'am, over to you. Would you like to share the slide, or would you like Pallavi to share?
I will share the slides. Thank you, ma'am.
Okay, welcome. Your time starts now.
Good evening, everyone, respected seniors, the committee body members, and the judges. At the outset, I would like to thank the organizing committee for giving me this opportunity. Today, I'm discussing the approach to short febrile illness. Fever is the most common reason in pediatric age group for OPD visit as well as for hospital admission. Short febrile illness is fever of less than 7 days duration. What are the causes of fever? As we all know, in India, infections like viral, bacterial, or parasitic infections are the most common cause of fever in any age group. Post-vaccination fevers are particularly common in children, and with peaking of summer, dehydration, heat stroke is also commonly seen. And in post-COVID era, not to forget the inflammatory causes like Kawasaki and MIS-C. How to approach when you get a child with fever? Based on initial impression, we just have to make sure whether the child is sick or unstable. You have to see the CBC, that is consciousness, work of breathing, and color of the child. Like if the child is depressed, lethargic, or irritable, he is having fast work of breathing, tachypnea, distress, grunt, or the circulation of the skin is impaired, like looking pale, mottled, or cyanosed, that child needs immediate stabilization even before taking history or examination. Coming to, if the child is stable, we have to proceed to history. History is the most important teaching to the diagnosis. As Jaideep sir has already discussed part of it, I'll just go through short few things like fever is abrupt in onset in malaria, UTI, LRTI, and viral illnesses, while it is insidious in typhoid. As sir already said, pattern of fever is not commonly seen nowadays due to the use of paracetamol and other anti-inflammatory agents. But What is important is change in behavior of the child, irrespective of the grade of fever or pattern of the fever. If the child is lethargic, not responding well to communication, or not feeding well, or irritable, not consolable, that child needs immediate attention. How is the child in interfebrile period will also help us to differentiate between a viral and a bacterial infection. You should look for urine output, which will give you end organ perfusion status. Other important factors to look in fever history are history of chills and rigor. As we all know, it is seen in viral, malaria, UTI, and pneumonia. For CNS localization, we have to ask history of altered sensorium, seizures, and history of crying during micturition for UTI, and history of blood in stools for dysentery. Don't forget to ask the history of travel, history of animal contact, history of affected siblings, or history of recent immunization. These history will help you to cut down many of the investigations. Coming to viral versus bacterial infection. Clinically, how would we differentiate a viral infection from a bacterial? Usually, a viral infection child comes with a multi-system involvement. Like a child with respiratory infection will have diarrhea also, but bacterial infections are usually localized to one system or an organ. Fever in viral infection is high at onset, but may settle down in next 4 to 5 days. But in bacterial infection, the fever is moderate to start and peaks in next 4 to 5 days in septicemia. Child is comfortable during interfebrile period, but in bacterial infection, the child looks sick in interfebrile period also. There is a usual common contact of history in viral infection, and bacterial infection, there may not be a contact history. Coming to examination, as we already discussed, general appearance of a child, we have to make whether he is sick or well, and accordingly we have to manage. Then prompt and rapid clinical assessment we have to do. Just make a habit or train your staff to mention vital signs on each OPD paper like temperature, heart rate, respiratory rate, blood pressure, and SpO2 of every child, which will give us a clue about the child's status. Look for localization of infection like urinary tract infection or CNS infection or any other system involvement. ENT examination of each fever child is must, I feel. Look for a patch on tonsils, bulging tympanic membrane, or ear discharge. And to rule out the inflammatory lesions, we have to look for mouth ulcers, mucosal inflammation, lymph nodes. And always don't forget to fully expose the child for examination of a rash or an ishkar hiding somewhere around the thigh or somewhere. And then do a focused systemic examination according to history and endemic diseases and the season, what you get commonly. How to approach a child which is coming to you with a history of 1 or 2 days fever. If the child is ill looking or it has got red flag signs, which I'll discuss later, you have to urgently investigate and hospitalize that child. And if a child is well looking and not having any major symptoms apart from fever, that has to be given symptomatic treatment, hydration advice, proper hydration and nutrition advice, and we can wait and watch, explain them the red flag signs and tell them to follow up after 2 or 3 days. The special circumstances are in febrile neonates and children less than 3 months and immunocompromised children. If there is a history of high-grade fever, that child needs to be investigated properly and many a times they need hospitalization. Be aware of these red flag signs: disproportionate tachycardia or respiratory rate, differential body temperature, cold extremities and delayed CRT. These are signs of circulatory disturbances. Chest retractions, meningeal irritation signs, purpuric spots, fascial membrane. These all direct us to the urgent hospitalization of the child. Also, there are some other indications for urgent hospitalization that like airway compromise, neonate, status epilepticus, altered sensorium, electrolyte imbalance, signs of severe dehydration, not feeding well, child with respiratory distress and SpO2 less than 90%. Now, coming to the fever with the localized sign, when we get a child with fever and localization of infection like cough or UTI or simple upper respiratory tract infection or ASOM, tonsillitis, in that child, we can just diagnose bacterial infection on OPD basis and give some antibiotics rationally prevailing to the particular organism depending on that particular diagnosis and age group. If we suspect some viral etiology, supportive treatment has to be given and followed up. And the cause is not evident and fever remains on day 3 or 4. But if the patient is getting better, if the fever is low, then we can just wait and watch. But if the fever is getting worse, evaluate for the localization, like again, re-evaluate for systemic localization or some evolving illness like typhoid or early Kawasaki signs. If there is no change, again, you have to wait and do some selective investigations. If the fever persists for day 5 and 7, watch for non-specific localizations like hepatosplenomegaly, lymphadenopathy, rash, mucosal involvement, and detailed lab investigations has to be done. Fever without focus is not PUO. It is a fever which when we do not get any system involvement. So these kind of fevers we get routinely in seasonal variation like malaria, dengue, enteric fever. These fevers have to be investigated according to the high index of suspicion of the epidemiology of that area and the season. Initially, supportive therapy should be provided. And if fever without localization we find, particularly neonates and infants less than 3 months are more susceptible to the fever, so they have to be thoroughly investigated. To sum up, if a child present with fever to the ED, we have to see whether he is immunocompromised. If yes, then evaluate thoroughly and if required, immediately hospitalize. If he is immunocompetent, then see for localizing signs. If we find some localizing signs, treat accordingly, tell them to follow up. If there are no localizing signs, then suspect the epidemiological diagnosis like malaria, dengue, enteric, and investigate accordingly. Take home message: identify and stabilize a sick child. Don't hurry to diagnose the probable cause rather than to treat empirically. Let the disease evolve and infection to localize. Treatment should depend on epidemiology and clinical findings. Thank you.
Yeah, thank you, Deepika. Excellent presentation of such a large topic in a short time. I would now request Dr. Jaideep sir to have his expert comments.
Yeah, thank you so much. Acute fever, short duration fever by definition is less than 7 days, subacute 7 to 14, and chronic more than 14 days. Excellently presented that triangle, the slides with the triangle, that's really appreciable. Most important take-home message from this presentation is that, number one, if an infant is less than 3 months, comes with fever, has to be admitted. We have to follow up the baby because they may deteriorate very suddenly and it's often difficult to monitor them. They may not have any localizing feature also. A sick neonate, of course, investigation has to be done. A well-looking neonate with fever ideally has to be admitted and monitored. Otherwise, the cause of fever might be difficult to diagnose in the first 2-3 days because that's probably an evolving phase. Maybe by 7 days, we have some localizing features, but typically the red flags that Madam has told, along with that, if there is regional lymphadenopathy, if there is joint swelling, joint pain, such focus should draw our attention. But there is no role of empiric antibiotic in a child who has come for acute fever. There is no role of starting cefixime. There is no role of starting cephalexin or just giving azithromycin when we do not know the cause of fever, because as we are telling repeatedly that antibiotics are not antipyretics. One message Dr. Amdekar gives that it's very, very relevant anytime is when we get a fever, when we are not sure about the diagnosis, best is to write it down on the prescription, what could be the cause, whether it could be viral or cause to be determined. Then at least that will deter us from writing an antibiotic and observe the child. So observation, red flags, admitting a sick child, that's probably the basis of this discussion of short duration approach. Thank you.
Yeah, thank you, sir, for the inputs. Now we'll go on to the next speaker, whose topic is rational investigation in short duration fever. She's Dr. Neena Fade. She's the pediatric hemato-oncologist from Solapur. Over to you, Dr. Neena, ma'am.
Thank you so much for your kind information. I would like to share my presentation.
Sure. Pallavi ma'am, can you do one thing? You can put on the YouTube that they have to write their MMC number, name, and
Yeah, ma'am. Already
IP number.
mentioned.
Because
Already
many
mentioned.
people are coming in the waiting, so they might not be knowing. Okay.
Yeah, ma'am.
As
Yeah.
well as well, Pallavi madam, just write on the YouTube message. Zoom guys is full. Please join on YouTube only.
Yes, sir. Yes, sir. Writing the same. Yeah. Thank you, sir.
Thank you, ma'am. Yes, Nina, are you able to do, or shall we ask Pallavi ma'am?
Yes, please ask Pallavi ma'am to share.
Pallavi madam, please share her presentation. Rational investigation in short duration fever, Nina Fade. Yeah, over to you, ma'am.
Yes, thank you so much. I'm Dr. Nina Fade. We'll be discussing about rational investigations in short duration fever. Next slide. Sorry. Investigation approach based on the time of arrival of patient. If the patient presents to you on day 1 of fever, and if there are red flag signs like tachycardia out of proportion and tachypnea out of proportion to fever, altered sensorium, impending shock, infant or children, presence with unconsolable cry, poor activity, sick look, toxic appearance, poor oral intake. If the child is immunocompromised, like patient on steroids, on chemotherapy, HIV, primary immunodeficiency patient. If fever is lasting for more than 3 days or a partially treated fever. The timeline for the investigation, if the fever presents, if the child is presenting with fever without focus and the child is not sick. On day 1, usually we don't need investigations as there may not be a focus, or we can consider it as a viral fever. Only a special situations like endemic area where the malaria is common, we can do the T-test investigation like peripheral smear to look for the malarial antigen, or if child is less than 3 months or an immunocompromised patient. After 3 days of fever, we can check the complete blood count. If total count is more than 15,000, do urine analysis and chest x-ray. If total count is less than 5,000, look at the platelet count. If it is normal, then consider as a common viral fever. If platelet count is low, then we can think of dengue fever and investigate accordingly. After 5 days, if the CBC is showing total count of more than 15,000, urine analysis and chest x-ray can be done, and along with that do CRP if it is elevated and there is no focal sign. Still, that you can look for occult blood, occult abscesses, or you can consider or think of Kawasaki disease. If total count is less than 5,000, look at the platelet count. If there is thrombocytopenia with elevated hematocrit, then IgG, IgM can be sent. If the thrombocytopenia is there with hematocrit of normal, consider of typhoid. And if it is along with there, if there is if there is a eosinopenia along with the fever and thrombocytopenia, you can send blood culture to confirm the diagnosis of typhoid, or you can send scrub typhus IgM ELISA. After day 5, if the fever is associated with lymphocytosis, anemia, thrombocytopenia with hepatosplenomegaly, consider for hematolymphoid malignancy. Now, investigations based on the age. If neonate is presented to your OPD with fever, so do the basic investigations like CBC with differential urine analysis, and we can think we admit the patient and we can do lumbar puncture, blood culture, chest x-ray, and stool testing in case of diarrhea. If the child is between 28 days to 3 months, urine analysis and urine culture with CBC is important. We can omit lumbar puncture if the child is well appearing and previously healthy. If there are no focal signs and WBC is within normal range, that is 5,000 to 15,000. If there is no pyuria or bacteriuria on urine analysis, or lumbar puncture can be postponed till the other investigations are available, or the child develops the focal signs. Stool testing in case of diarrhea and chest x-ray if there are focal signs, clinical signs present on the physical and lab examination. Between the 3 months to 3 years, again do the basic investigation. If the WBC counts are more, analysis and urine culture with unexplained fever, and lumbar puncture if there is a neurological sign present. In special cases like immunocompromised condition, first do complete blood count on even day 1, because if there is a febrile neutropenia, which is defined as absolute neutrophil count less than 1000 along with the fever of more than 38°F lasting for more than 1 hour, then admit the child and start do blood culture or urine culture even before starting antibiotics, and do chest x-ray. If fever lasts for more than 7 days, investigate for fungal infection and HLH. Now, what we will see in a complete blood count, usually if the patient presents with the anemia, we can think of following differential diagnosis and we can do the specific investigations accordingly. In case of anemia, we can think of malaria, trypanosomiasis with microangiopathy, HUS, mycoplasma induced hemolysis. If the WBC count is showing neutrophilia on day 1, usually it can be stress induced, or otherwise can be bacterial or fungal infection, invasive viral infection, hidden abscess, inflammatory disorder. If the CBC shows neutropenia, we can think in terms of salmonella, rickettsia, and pertussis. If we find the lymphocytosis, common viral infections like E. coli or Coxsackie virus, pertussis, rickettsia, EBV, CMV, toxoplasma, we can suspect of malignancy. In lymphopenia, acute bacterial infection or brucellosis. Thrombocytopenia, the platelet count less than 150,000. On first week, we can think of viral infection, malaria or dengue. On week 2, we can suspect of malaria, scrub typhus, typhoid, leptospirosis. If with abnormal complete blood count, clotting abnormalities are there, think of severe infection or a gram-negative sepsis. On urine analysis, we should do urine analysis of most of our patients because it is the commonest cause of severe bacterial infection in infancy and early childhood. So the sample collection is important in this case. In less than 2 years, catheterization or suprapubic aspiration with aseptic precautions is important. And in child with a voluntary control, clean catch method should be done. Now, when to send urine culture? If we find the WBC in urine routine microscopy more than 5 WBC per high power field, or if there are more than 2 to 3 RBCs per high power field, if nitrites or ketones are present in the urine, or bacteria or yeast is present in our urine routine report, then you should definitely send for urine culture. Now, other inflammatory markers like C-reactive protein and procalcitonin is also important in some of the cases. The sensitivity and specificity of C-reactive protein is better than that of WBC count more than 15,000, and it has a better prognostication. The procalcitonin is increased in inflammation and bacterial infection. It also has a better sensitivity, specificity, and predictive value than that of WBC count. Now we'll come to the specific diagnostic pointers. If patients presents to you with fever, conjunctival congestion, jaundice, severe myalgia, muscle tenderness, you can send for leptospira IgM. If the patient presents with a fever, severe myalgia, conjunctival congestion, and rash, for first 4 days, the NS1 can be positive, or otherwise day 5 onwards, we can send for dengue IgG IgM. The fever with chills, rigor, especially on alternate days with splenomegaly and migrant patient, investigate for malaria like rapid antigen test and peripheral smear. Fever with rash, toxic loop, no response to usual antibiotic, ischial present, investigate for scrub typhus. Now, the specific investigations according to the endemic disease. For example, nowadays we have already faced the COVID situation. In that case, we can send COVID PCR in a COVID pandemic area. So my take-home message in the first 3 days usually, usually investigations are not required unless definitely indicated. Uncomplicated or not sick, non-sick patient in short febrile illness, no need of investigations. If sick or unusual symptom at any time point, do appropriate investigations. If your area report any specific or endemic disease, specifically screen for it. Always communicate patient or relative why to investigate and why not to investigate at that point of time. Thank you so much.
Yeah, thank you, Dr. Neena. As you are a hemato-oncologist, it is a topic of your interest of investigations. So nice presentation. Now over to Dr. Jaideep sir for the expert opinion.
Thank you, Dr. Neena. It was an extensive presentation. Just few points I would like to stress is that we must have a very low threshold for doing an urine routine and culture, as you have told already. So any child coming with a short duration fever when we cannot localize any infection or any focal point, then better to go for a urine routine and culture. Of course, it can be urine infection can be detected by urine routine culture very early. So we must have very low threshold for that. And as you have told, the seasonality and endemicity of the diseases should always be kept in mind. And likewise, malaria, dengue, and scrub also. Nowadays, so many scrubs are being diagnosed. So it should be done. Then we must be a bit liberal if it's an infant coming with fever as regards to investigation. There are urine, chest X-ray, and other investigations should be done. Basically, the investigation in children post infancy should be guided by whether the child is sick or whether the child is well looking. Now, in sick looking, the investigation should be done a bit liberally, and of course the clinical examination should guide us in the line of investigation. So a sick child, other than the whole hematological parameter, CSF study, sepsis screen are of immense importance. Now regarding CRP, well, CRP, serial CRP has got more clinical relevance in infancy or in younger children. In older children, CRP should be done a bit judiciously, and procalcitonin should be reserved for only few critical cases where we have to prognosticate and we have to change the antibiotics. Another investigation I would just like to highlight a bit is the use of ultrasonography, which is bedside among the imaging, which is bedside, easily done. Even we can diagnose pneumonia, sympneumonic effusion, and pleural effusion by USG also of the chest and of the abdomen, any abscess, any hepatomegaly, which is sometimes in an obese child difficult to diagnose, and the liver texture, that can be very easily done by a bedside ultrasonography. So that's one investigation that often in our hospital we do a bit liberally, a bedside USG. So above all, it's the clinical feature which should guide us and which should be really the deciding factor for doing investigation. Thank you. Thank you so much.
Thank you, Dr. Jaideep Chaudhary, sir, for your expert opinion. Now, for the next part of the session, I would like to welcome Dr. Pratibha ma'am, my co-moderator. She is the pediatric pulmonologist from Sholapur. Over to you, Dr. Pratibha ma'am.
Yes, thank you, Renu. With continuation, we'll continue this academic feast, and I welcome Dr. Malvika Kulkarni from Shahada Nandurbar for explaining us approach to the pyrexia of unknown origin, which is very important topic. Let us get continue with the same thing. Welcome, Malvika.
Am I audible?
Yes, yes.
Yeah. Thank you, madam. My topic for today is approach to pyrexia of unknown origin, and I am Dr. Malvika from Shahada of district Nandurbar. So before I become a pediatrician of unknown origin, I just wanted to show that Nandurbar is in the northernmost district of Maharashtra, and the yellow dot is where Shahada is. And we are pretty well known by now for our malnutrition, sickle cell disease, and our remote tribal hamlets. So moving on to pyrexia of unknown origin, classically it is defined as a temperature of more than 38 degrees or more than 100 degree Fahrenheit documented by a healthcare worker, and for which no cause could be identified after more than 3 weeks in the OPD or more than 1 week of hospital stay. That includes a careful history, physical examination, and initial lab assessment. We have to differentiate it from pseudo-PO, in which there are successive episodes of benign self-limited illnesses where the parent perceives it as a one prolonged fever episode. We have to carefully rule it out. Then there are other definitions like healthcare associated PO, immunodeficient pyrexia of unknown origin, and in HIV infected patient, there is HIV related PO. Moving on to the etiology of the PO, most commonly it is the infections, which are around 50 to 60% of the cases, especially in children below 6 years of age. In more than 6 years, the percentage slightly decreases. In rheumatological causes, around 10 to 12%. Neoplasms account for 5 to 10% of the cases. And in miscellaneous causes, there are 2 to 5%. And we have to remember that 15 to 20% of the cases are undiagnosed and idiopathic. So in the infections, generalized infections, the common bacteria are Salmonella and tuberculosis. Rickettsial infections, viral infections like CMV and Epstein-Barr virus, parasitic infections like malaria, and less commonly we have Brucella, Toxoplasma, Leptospira, and rarely viral infections like arbo and enteroviruses, and HIV during seroconversion can present as PUO. Then there are fungal infections that cause PUO. In the localized infections, we have infective endocarditis, pyelonephritis, liver infections like bacterial cholangitis, hidden urinary tract infection, chronic or recurrent UTIs, chronic or recurrent upper respiratory tract infections like otitis media, pharyngitis, mastoiditis. Sometimes occult abscesses in the abdomen could present as a pyrexia of unknown origin, especially perinephric or psoas abscesses. Less frequently, we do have osteomyelitis and septic arthritis that could present as a PUO. In the non-infectious causes, we have rheumatological diseases like JIA and SLE. And now recently, we do have to suspect multisystemic inflammatory syndrome post-COVID. In hypersensitive diseases, there are drug fevers. Granulomatous diseases like Crohn's and ulcerative also have to be kept in mind. In neoplasms, more commonly, there are lymphomas and leukemias. And then there are the rare tumors. In the miscellaneous disorders, the first thing that comes to mind is the hemophagocytic syndromes, drug fevers. Factitious fever has to be kept in mind, and it was advisable to hospitalize these patients and diligently observe the parent and the child. There are other diseases like diabetes insipidus, and in our area, the sickle cell disease could present as a PUO. Then there is Kikuchi-Fujimoto disease, thyrotoxicosis, that could present as PUO. In approach, we always have to remember that it is a common disease with an uncommon presentation rather than an uncommon disease that presents as PUO. So in our assessment, if the child is serious, we need to first stabilize the child with our ABCD and resuscitation. We'd have to take a detailed history, which has to be meticulous, and we have to reassess all our sources of history. In physical examination, we have to be very careful to pick up subtle signs. We need to review all the previous investigations, the antibiotics, the course timeline that has been given. Then we have to list the problems. It is always a good idea to hospitalize these children. Counseling of the parents has to be done. We have to start give supportive treatment whenever needed. The investigations have to be very focused. we initially give the preliminary investigations, then depending on that, the results, we do the primary or the secondary investigations. Approach in the history, we are importantly looking at the age of the child, which would classify the illness or the infection that could be predominantly seen in that age group. We are looking at the residence for endemicity or the other sanitation problems. Immunization status could exclude the illnesses for which the child has been immunized. A travel history, zoonosis or pica, medication history for duck fever and supplementation, any previous surgery or insect bites. Certain points that are overlooked in PUO are a recent admission to school, which could cause consecutive series of self-limiting illnesses and could be perceived as PUO. Unsafe food, unpasteurized milk, especially goat milk, could cause bacterial infections like E. coli and Salmonella. A recent immunization with a live vaccine could rarely cause fever. An adopted child could be harboring a urinary tract infection or tuberculosis. Blood administration could cause viral infections. In the investigations, a thorough head-to-toe investigation is crucial. In the vitals, we could have a relative bradycardia, which could suggest an acute infection like Salmonella. Weight loss could aim towards neoplasms or chronic infections. A growth faltering could suggest TB. In skin, we are looking at petechiae or rash or issue. In hair loss is there in SLE and chronic disorders. Absence of sweating during fever could suggest ectodermal dysplasia or diabetes insipidus or dehydration. In the eyes, we are looking at the palpebral conjunctiva for conjunctivitis, fundus in toxoplasmosis and TB and vasculitis. The oral cavity gives a lot of clues with regards to inflammatory bowel disease, SLEs. Pharyngitis is common in Epstein-Barr virus or a leptospirosis. Gums and teeth for ectodermal dysplasias. Then there are lymph nodes that we have to look for, generalized lymphadenopathy, the location if there are matted. In the chest, we are looking at pleural effusion, abdomen for hepatosplenomegaly, tenderness or mass. Any kind of myositis or arthritis or serositis could give us a clue about a rheumatological cause or a brucella or an inflammatory bowel disease. The red flag signs for PUO are weight loss, night sweats, focal findings on examination, signs of organ dysfunction or unstable vitals, which could suggest sepsis. The investigations should be based on our history and our clinical findings. They have to be stepwise. Pace should be depending on the seriousness of the child. And we should always aim for the gold standard tests. And the test should be focused, reliable, and rational. So once we have done the history and the physical examination, our basic lab would reveal a lot of information with regard to the diseases in infections that we are looking at, which my previous speaker has already covered. I would just add that CRP has a negative predictive value in a bacterial infection, but if a high CRP is noted, then it could have a positive predictive value too. Echocardiography is a basic investigation if infective endocarditis is suspected. We do a urine analysis to reveal a pelvic infection. It could give an idea. A chest X-ray is essential for tuberculosis. USG could give us a guidance about basic hidden abscesses or hepatosplenomegaly. Cultures if sepsis is suspected. In malignancies, we are looking at pancytopenia with an elevated LDH. Retic count is low in leukemias. USG would suggest give us hepatosplenomegaly or organomegaly. A chest X-ray would reveal hilar lymphadenopathy. In autoimmune disorders, the clinical manifestations are the ones that are very important to arrive at a diagnosis. But here again, a raised ESR or CRP is always helpful, especially while monitoring the child. Then serum ferritin in histiocytosis is important. So once we have arrived at a probable diagnosis, further investigations would depend on what diagnosis we have come at. So depending on that, if we are suspecting a viral infection, serology comes into play with for Epstein-Barr or infectious mononucleosis or CMV. Brucella also can be diagnosed with serology. Blood culture is for sepsis is indicated. Molecular testing with polymerase chain reactions is done for TB, CMV or HIV. CSF cultures whenever a CNS infection is suspected. MRI brain is for CNS infection. In malignancy, we opt for bone marrow biopsy, aspiration, lymph node biopsies. And we do a uric acid level for tumor lysis syndrome. CT abdomen, chest and pelvis has to be done if we are suspecting, and tumor markers for the specific tests. In rheumatology, we have to do the various assays for diagnosing of the rheumatological cause. Among the advanced tests, we have MRI and contrast enhanced CT scan or PET scans to diagnose a neoplasm, inflammation or infection. We have to opt for a GI scopy or biopsy if we are suspecting an inflammatory bowel disease. Now, if in spite of all these investigations, the child has persistent fever and appears sick, it is always advisable to refer the child or at least consult with a specialist, which would be an infectious disease specialist or a rheumatologist, a hemato-oncologist or a geneticist. The management, apart from the specific and supportive treatment, we need to discontinue all the non-essential medications. Antipyretics, it has to be emphasized to the parents that paracetamol is the drug of choice. Sometimes we do start non-steroidal anti-inflammatory drugs, especially in when we suspect JIA. And at all costs, we need to avoid empirical antimicrobial therapy, as it will mask the location of the disease, and also it would be difficult to isolate the pathogen. So in the outcomes, usually there is a treatable cause that is found, and or there might be a self-limiting disease. Most cases that are diagnosed will resolve in a week or two. The undiagnosed cases may become afebrile after a couple of weeks. A few of them do evolve into JIA or inflammatory bowel disease. The mortality is variable, but is placed at around 2 to 5%. So this is a rural pediatrician thanking MAHA-IAP to give me this opportunity to present this presentation. I also thank Dr. Pramod Kulkarni sir for guiding me in this presentation. Thank you.
Well, Malvika, this was a very crisp and point-wise talk. Now, I welcome Dr. Pramod Kulkarni sir for his enthusiastic expert opinion.
Thank you very much and good evening, MAHA-IAP office bearers, stalwarts, then the moderators and the attendees and the presenters on top of that. So, Dr. Malvika, you presented it quite well. To sum up, or the messages which I would like to again reconfirm and pass on to the audience. Basically, PO, it's an uncommon situation in general pediatrician's office. When it comes, let me tell you, it's very extensive, very expensive, and very challenging clinically. So these are the three basic things to be understood. Most of the times, hospitalization for appropriate timing of various investigations and next dependent decisions and the second opinions needs hospitalization. Thirdly, the tests to be done, the investigations, the uncommon investigations for the rare diseases, as we heard, doing it without standardization, without appropriate collection, transportation, storage, and processing, and again the interpreter. Many of the imaging studies or the lab studies are observer dependent. So the tests which have to be done at this level have to be very thoughtfully and rationally selected, because we are spending more. We have to take care that the expenses are paid off with good and reliable results, which are going to help us in ruling in or ruling out specific disease. The investigations, some of the investigations may have to be repeated to observe various trends developing, which can be a very important clue in some of the chronic diseases, especially rheumatological and malignancy or the autoimmune diseases. So this is about the investigation. And let me tell you something about the treatment. The first thing I would recommend, if the child is stable, stop all antibiotics. It is very helpful in giving us a probable suppressed bacteremia in our blood cultures. Number two, it will take away the drug fever, which is a hypersensitivity fever in most of the cases, and it will save the cost. Most of these kids, they resolve the fever with or without diagnosis by 8 to 10 days. And even few of them who are not diagnosed, it happens quite commonly, which we have to disclose at outset itself. Maybe a possibility in one quarter cases, we may not be able to reach a diagnosis, which is very purpose of admitting the PO cases. So I will say you have to be a little liberal but rational and more keen in daily clinical examination and deciding about the investigations and second opinion in diagnosis of PO. You need a lot of help in that. Please involve experts and your friends who have dealt with such pyrexias. That's my message. Thank you.
Thank you, Kulkarni sir. It was very nice and crisp sum up. And now I welcome Dr. Ashutosh Paldiwal for his next talk of interpretation of blood cultures. We always send blood cultures, but we get stuck how to interpret it. Let us welcome Ashutosh Paldiwal.
Unmute yourself. Ashutosh, unmute yourself.
Dr. Ashutosh, share your screen. खाली आहे ते शेअर करा तुम्ही. नाही अजून.
Is it
slideshow
visible?
No.
Slideshow करना.
केला. Is it visible?
No, not. Slideshow. शेअर स्क्रीन मधून गेलास का?
तुम्ही खाली शेअर स्क्रीन आहे ना?
हो सर.
बंद करावा लागेल आता तुला परत.
Sir, presentation this.
Yes, there.
Presentation is visible, sir.
Yes. Good evening, everyone. Respected IIP President, Secretary, all the judges and panelists. I am Dr. Ashutosh Paldiwal from Akola, and my topic for today is interpretation of blood culture. At the outset, we should see some definitions which are important for this particular topic. Now, bacteremia. Bacteremia is nothing but the presence of bacteria in the blood. What is blood culture? Blood culture is a blood specimen submitted for culture of microorganisms. Bloodstream infection is an infection associated with bacteremia or fungemia. And the most important is contaminant, a microorganism isolated from a blood culture that was introduced either during specimen collection or during processing of the sample. So why blood culture is important? It is basically done to confirm the infectious etiology, to guide antimicrobial therapy, and it decides the duration of antimicrobial therapy. The factors which contribute to blood culture sensitivity is, the most important one is blood volume. It is blood periodicity, that is whether the infection is transient, whether it is intermittent or continuous, the causative organisms, and the bacterial density. So how to collect a blood culture sample? First of all, we should disinfect the area with a sterile gauze, which is containing with alcoholic or chlorhexidine scrub. We have to disinfect the bottle itself, the opening of the bottle itself, put the gloves and the mask, perform venipuncture and draw the appropriate volume of the blood. The volume of the blood which has to be drawn will be explained in the next slide. Withdraw needle and put a sterile gauze without touching the needle. That is most important. Without changing the needle, puncture the bottle cap at the perpendicular angle and inject the blood into the bottle. Now, few important points: we should never draw the blood culture while inserting a catheter. If a catheter is needed, a second puncture must be performed. And we should never take a blood culture sample from indwelling lines. if we are inoculating an anaerobic blood culture, bottle only if the patient has high risk for the anaerobic infections. So as I told, the volume of the blood is most important. So how much volume has to be collected when we send the sample for blood culture? It mainly depends upon the weight and the age of the child. If the weight is less than 1 kg, the sample is 0.5. If the weight is 1 to 5 kg or the child age is 2 to 5 years, the sample should be 0.5 to 1 ml for 1 to 5 kg. And if the age is 2 to 5 years, it has to be 2 to 5 ml. And if it is 5 to 15 years, then 5 to 15 ml. So roughly it depends upon the age that it is equal to the age of the patient. The Bactec bottle should never be refrigerated. That is the bottom line of this slide. And it should be stored at the room temperature. In special situations like infective endocarditis, we should collect 3 blood culture samples and we should dispatch the bottle to the lab as soon as possible. Now, what are the recommendations for incubation? Now, the standard recommendation nowadays that we should incubate the bottle for 5 days. But the results demonstrate that the clinically significant isolate were recovered within first 3 days of the incubation. So if the pathogen is growing within first 3 days, it is usually a clinically significant isolate. And if it is growing after 3 days, it is usually a contaminant. And we have to ask for the extended incubation for some organisms like fungus or brucella. Now, the question arises, is that organism grown is a contaminant or a pathogen? It is always a dilemma. The contamination of the blood culture during collection is a significant level, causes a false positive result. A false positive is defined as the growth of the bacteria in the blood culture bottle that were not present in the patient bloodstream and were most likely introduced during sample collection. Collecting a contaminant-free blood sample is the most critical point in collecting a blood culture sample. Now, that is always a dilemma. I told you that is a growth versus contaminant. So if a pathogen grown in the culture bottle is Staph aureus, Streptococcus pneumoniae, Enterobacteriaceae, Pseudomonas or Candida, it is always predictive of true bloodstream infection. If the normal skin flora, that is Corynebacterium or Propionibacterium are grown, it almost always represent a contaminant. But there are in a few cases, like if some organisms like Streptococcus viridans, Coagulase negative Staph aureus, Enterococci, which are present in the patient and the patient is immunocompromised or is having an indwelling catheters or is having a prosthetic valve, these organisms become significant and they can cause probable bloodstream infection. So if we are getting a contaminant or if we are clinically suspecting that the patient is suffering from some bacterial infection and we are not getting the culture as positive, so what to be done? We can repeat the blood cultures, and even if we are getting it negative, we should consider for non-infectious etiology and investigate for viral etiology or some non-culturable microorganisms. Now, up till now, what we have seen is about the first part of culture report, that is about the growth of the organism. Now, the next part is how to deal with the antibiotic sensitivity of a particular antibiotic against the organism. So the important quantitative measure that is MIC. MIC is nothing but minimum inhibitory concentration. It is the lowest concentration of antibiotic needed to inhibit the growth of an organism. The lower the MIC, the more effective the particular antimicrobial agent against that organism is. So it is always an inverse proportion with the sensitivity. Now, as we can see in this report, we can see the organism grown in culture is Klebsiella pneumoniae. Now, interpretation, we can see there are few antibiotics which are sensitive. For example, amikacin is sensitive, TG cycline is sensitive, even piperacillin tazobactam is sensitive. But how to interpret means which antibiotic has to be started in severe infection, it depends upon MIC. The lowest MIC in this case is of TG cycline. So it would have the TG cycline is the most sensitive antibiotic. So MIC does help us in selecting a proper antibiotic for a particular organism. Now this is how MIC is calculated. A quantified amount of microorganism is added to each well with varying concentration of 8 antibiotics. As we can see in this chart that A to H, there is various antibiotics has been added. The black circles over here indicate no bacterial growth. So we can see in this, for example, for antibiotic A versus C, in C, we are getting the dark circle at a very minimum concentration, that is at 0.5 as compared to A antibiotic. So C is much more sensitive as compared to A. So in this way, MIC helps us in selecting a particular antibiotic. So there are some novel identification techniques. If we are not getting a blood culture report as positive, we can go ahead with bacterial 16S PCR. If blood culture has not yielded a pathogen and bloodstream infection is strongly suspected, we can go ahead with newer techniques, that is 16S PCR, which can be performed. Bacterial ribosomes are used in this techniques. This can detect fastidious organisms which can clinically help us and which remain undiagnosed. This is particularly useful for culture negative endocarditis. So after doing this, the take home message for this presentation is the blood culture still remain the gold standard for diagnosis of bloodstream infection and guide us for antimicrobial therapy and also help us to decide the duration of the therapy. Judicious use of blood culture should always be employed. Always ask whether does it fit with our clinical picture. Numerous factors impact our blood culture sensitivity, but adequate blood volume still remain of utmost importance. When interpreting a positive blood culture, adopt a holistic approach. Therefore, MIC still remains the most important part while interpreting a blood culture report. When probability of bloodstream infection is very high, but no organism is grown, always go for some newer techniques like 16S PCR testing. That's all for now. Thank you.
Thank you, Dr. Ashutosh. It's really very nice interpretation because we send blood cultures for choosing our antibiotics so that we can avoid the antibiotic use. If we can able to interpret it very perfectly, then it's worth sending blood culture, isn't it? So now onwards, we can interpret it very perfectly. Now I welcome Dr. Pramod Kulkarni sir for his expert opinion.
A fine presentation and very well presented, Ashutosh. Congratulations for that.
Thank you.
About blood culture, it still remains the gold standard for bacterial and fungal infections. There is no doubt about it. If used judiciously and rationally, it is the best investigation, let me tell you. Even doing a CRP, we are spending at least 300 to 400 rupees. For a procalcitonin, we are ready to spend 2,000 rupees. In comparison of that, automated blood culture, which is available about 800 to 1,000 rupees in most of the reference labs, is a reasonable expenditure to get the appropriate diagnosis, confirmed diagnosis. Not only that, which also comes with a sensitivity or resistance pattern of the bacterial organism or fungal organism which is responsible. That is the important thing. Not to overemphasize, the most appropriate collection, transport, as soon as possible transport to, for the plating. And now we know the Bactec and Bactalert. These are the automated systems available almost at the big places as well as important district places. And the hesitation from the practitioner side of not doing cultures is not acceptable anymore. You have to do blood culture in suspected bloodstream infections and when you are suspecting typhoid fever without doing the Vidal test in the first week. So Salmonella is very easy organism to go. Secondly, the most important aspect of blood culture is the antibiotic stewardship applications of it. If you have got 2 consecutive negative blood cultures or the first positive and second negative blood culture, you can tailor your continuation of systemic antimicrobial therapy, which is very important in bloodstream infections as well as the serious infections. So that way, blood culture, let me tell you again, stands the time-tested gold standard of bacterial and fungal diagnosis. Please go ahead with that. Use it more liberally without hesitation, but with appropriate care of collection and soon transport. Thank you very much.
Thank you.
Thank you, sir. Really, you are so true. By using the blood culture, we can avoid the antibiotic excessive use and abuse of it. So in continuation with the same thought, I welcome the next speaker, Dr. Sushruta Kulkarni Deshmukh, for giving antibiotic use. I welcome you, Dr. Shushruta.
Yes, is it visible?
Yeah, it's visible with.
Oh, yeah. So in continuation with the beautiful talks given by my colleagues on infectious diseases, I will be concluding the last one with rational use of antibiotics. I'm Dr. Sushruta Kulkarni Deshmukh from Pune. So as we all know, the definition of rational antibiotic therapy is using the antimicrobial only when indicated, by choosing the right agent at the right dose, by the right route, and for the right duration. It is the need of the hour because we are aware of the consequences of inappropriate use, them being increase in the adverse effects, increase in the cost to the patients, change of the microbiome in the surrounding area, and emergence and spread of antibiotic resistance. So still, good hygiene practices, good nutrition, and immunization would go a long way in curtailing the irrational use of antibiotics. Now, before starting on an antibiotic, we have to answer multiple million-dollar questions. Primarily, whether is it an infection? Now, every infection is usually associated with a fever, but the contrast is not true in the sense every fever may not be an infection. Whether it is a bacterial or viral infection, I would not go into the details as my colleagues have already mentioned it. If the infection is bacterial, which is the suspected organism, that would depend upon the age of the child as well as the site of infection. Now, is there a need to treat with an antibiotic? Well, some infections like acute otitis media in a child more than 2 years old who's immunocompetent does not require treatment, at least for the initial 2 to 3 days, so we can hold it. What is the antibiotic? What is the organism sensitive to? This will depend upon the local antibiotic sensitivity data. Now, which antibiotic to use? What is the severity of infection? It again depends upon host factors, the age of the child, as well as whether the infection is community acquired, hospital acquired, or even the site of infection. Has there been a prior antibiotic use? Now, if an antibiotic has been used 30 days prior to the presenting complaints, there may well be a chance of resistance in the resistant organisms prevailing. So it's better to use an antibiotic from another group. What are the host comorbidities, if any? If there is HIV, suppressed, or severe acute malnutrition, or underlying organ dysfunction, as in a hepatic or a renal comorbidity, and what would be the right route, dose, and duration, which would depend upon the pharmacokinetic and pharmacodynamic properties of the antibiotic. Now, regarding the different types of therapy, the first would be definitive treatment, which is relatively simple because the organism has been identified by culture. But here a word of caution that we have to rule out contaminant, commensal, or a colonizer because they generally tend to be benign and need not be treated. The treatment here would depend upon the culture report. We would use the antibiotic with the narrowest spectrum with the lowest MIC. The antibiotic should reach the site of infection, and due consideration must be given to host comorbidities. The most difficult, however, is empiric therapy, which you most often have to resort to. Well, it's a reasoned guess using your logic. One should be reasonably sure about presence of infection and the necessity to treat the infection. And ideally, every attempt must be made to isolate the organism by sending appropriate tests before taking a judicious decision whether to embark on empiric therapy or not. Prophylactic therapy, here we are giving treatment before the infection has occurred to prevent the infection. Here the organism should be a known organism and it should pose a serious threat to the susceptible host. Ideally, would use the antibiotic with the narrowest spectrum and for the shortest possible duration. For example, giving preoperative cefazolin 30 minutes prior to a clean surgical procedure to prevent contamination of the operated site by the local skin flora. So also treating contacts of meningococcal meningitis to prevent a serious infection in the contacts. However, there are some red flags which warrant early empiric therapy, which would put us on a high alert because we may not have enough time to treat. The age of the child being less than 3 months, the child is looking excessively lethargic or irritable. tachycardia and tachypnea are disproportionate to the fever, evidence of sepsis, fever in any immunocompromised child, and unexplained fever in an ICU setting or an underlying host disease. Now, what is escalation and de-escalation? Escalation is simply putting stepping up of the antibiotic therapy. It is required when the patient is not responding after you have ruled out complications. And secondly, if a resistant pathogen has been identified on blood culture and you've started a different empiric therapy. When it is not indicated is within 48 hours of starting of the antibiotic, because some time should be given for the antibiotic to show its action, or you're using an empiric therapy where a pathogen on blood culture has been identified, which is anyway sensitive to it. And third is the child is improving despite the culture report showing resistance. This typically happens in an OPD setting where we are treating urinary tract infection with cefixime and the culture is growing an extended spectrum beta-lactamase. Here, the patient is responding, and we should keep in mind that cefixime achieves a good concentration in urine. However, word of caution is we should be aware about the natural course of the evolution of the disease. For example, typhoid fever takes a good 5 to 7 days to resolve. So despite the child being on the appropriate antibiotic and the fever not settling by day 4, we should not be jumping to use another antibiotic. Just wait for the evolution of the fever and for it to deference. De-escalation is also as or even more important, I would say, than escalation, because we want to reduce the development of antibiotic resistance and adverse effects. Here, we judiciously need to de-escalate when the culture is showing an organism which is sensitive to the drug with a narrower spectrum, and we definitely need to step down. Here, we are a little skeptical or scared to step down because we feel, why rock the boat when the patient is responding to the treatment? But it is a very important and integral part of rational antibiotic therapy. Now, I would talk about switch. We need to change when the patient is doing well, we need to change from parenteral to oral therapy when we require to discharge the patient to decrease the hazards of in-hospital stay as well as the cost of therapy. OPAT is shifting to the same parenteral therapy on an OPD basis. This is sometimes required for chronic infections, such as a chronic pyelonephritis, where the antibiotic needs to be continued in a parenteral form, but ideally we would like to use an antibiotic which can be given only on a single OD dose basis, so the patient can come and take the antibiotic on an OPD basis. Now, the different types of switch being sequential, where I'm using the same antibiotic and changing from injectable to oral, as in community acquired pneumonia, where I'm treating with injectable amoxiclav and discharging the patient on an oral amoxiclav. Second one is switch, where I'm shifting to a different molecule from the same class. As in enteric fever, I'm treating the child on with ceftriaxone, and on discharge, I'm putting the child on oral cefixime. Both ceftriaxone and cefixime belong to the third generation of cephalosporins, so I'm not changing the spectrum. And the last is the step down, which is actually a de-escalation, where I use a different molecule with a similar spectrum. For example, community acquired pneumonia on injectable ceftriaxone, I'm shifting it to oral amoxicillin. Now, quickly going through the commonly seen scenarios in OPD where we tend to make mistakes. With pharyngitis, as we all know, most commonly viral, rarely bacterial, out of which the most common would be streptococcal infection. There is a need to treat because of prevention of suppurative and non-suppurative complications. Here, the rationality lies in the fact that Streptococcus pneumoniae is extremely sensitive to penicillin, hence amoxicillin should be the drug of choice. The irrational or the mistakes which we tend to make is we try to use amoxiclav, but clavulanic acid is absolutely not needed here because Streptococcus pneumoniae is not producing beta-lactamase enzyme, as well as we tend to, so amoxiclav would be an overkill, and we tend to not give a treatment for 10 days. That it is absolutely necessary to treat the child for 10 days. Acute diarrhea, mainstay of therapy being low osmolar ORS and zinc. Remember, antibiotics have to be used only in bloody diarrhea or dysentery, drug of choice being cefixime. And the irrationalities committed here would be unnecessary use in viral diarrhea and combination of quinolones or metronidazole. Well, in pediatric, there is usually never a combination of a bacillary dysentery as well as an amoebic dysentery. Besides, quinolones and metronidazole have different half-lives and pharmacokinetic and pharmacodynamic properties. So when do I use antibiotics in my OPD? Very few occasions, sick or a seriously ill child. severe or persistent upper respiratory infections such as sinusitis or ASOM, pneumonia with the child has fever, fast breathing and retractions, fever without a focus where you would suspect oral bacteremia as in UTI, abscesses or typhoid fever, loose stools, mind you, only when there is visible blood, skin and soft tissue infections, and prophylactic antibiotics only with specific indications. So my basket would be enough if I'm having 3 antibiotics on an OPD basis. That's why I'm calling them 3 ACEs, amoxicillin and amoxiclav for RTIs, cefixime for UTI, enteric fever and dysentery, and ciprofloxacin and ciprofloxacin for skin and soft tissue infections. Rarely in atypical infections, we would need another antibiotic such as a doxycycline or azithromycin. So my take-home messages today will be, every fever is not a bacterial infection. And most of the times, primary care infections do not require any antibiotics. Common bacterial infections in our primary care setting require a single narrow spectrum antibiotic of the shortest duration. Every time, a best attempt should be made to prove bacterial infections by sending appropriate cultures, and rational choice of antibiotics is a must for best patient outcome and to prevent the antibiotic abuse and preserve antibiotics for future. Thank you. So sometimes you really need to step back to save the others. So thank you so much. I thank the Women's Forum as well as MAHA-IAP for giving this opportunity. I'm a profound deep gratitude to Dr. Pramod Kulkarni for mentoring me throughout this. Thank you so much.
Thank you, Dr. Sushrita. It was a very nice. And one more take-home message I would add. From tomorrow onwards, the wise is one who uses his antibiotic less, है ना? वही है सिकंदर जो एंटीबायोटिक बहुत कम यूज करेंगे, है ना? तो that is one more take-home message from Sushrita and WC committee. So I request Dr. Pramod Kulkarni sir. I think this is a very close topic for him. He would add expert comments very nicely. We are waiting for you, sir.
Thank you very much, Sushrita, for the nice presentation. And there is hardly anything to overemphasize about rational antibiotic use. Over last decades, we have heard about it so much, so many times. Now we know every word of rational antibiotic presentations. This is the time now to practice it. We have to practice it proactively. And let me appeal you, do it personally and you will lead the flock. People will follow your prescriptions of no antibiotic unless dire necessity. See, here at Referral Institute, big institutes, we are observing very bad antimicrobial resistance and its outcome-related effects. So gram-negatives are gone, almost 80% are resistant. Gram-positive, MRSA is the biggest problem. Streptococcus pneumoniae is also becoming resistant in invasive infection. Now we have to add vanco for suspected meningitis. And the fungi, let me tell you, the dermatophytes are out of control now of the old generation antifungals. So this is the scenario everybody is facing. Let us stop thinking about the rational antibiotic practice and just start doing it. And the very simple way, put down your diagnosis, as Dr. Amdekar always says, jot down what is your diagnosis and what purpose you are writing the antibiotic. And I highly recommend and highly appreciate the 3 essays and the half atypical coverage with either azithromycin or doxycycline, more than sufficient for secondary level care. And with a solo clinic or a cooperative clinic, I will say sufficient to use ceftriaxone, nothing beyond that. And I will appeal, please do not use aminoglycosides. They are not at all necessary. In almost 99% of the situation, they have been abused over decades. So, my dear friends, let us start practicing rational antibiotics and really translate it into our prescriptions and benefits of society, our own community, and our future generations. Thank you so much.
Yes, sir, we'll definitely agree with your appeal. And this is very need of the time. Even I expect Dr. Jaideep sir, कुछ add करेंगे sir आप? Dr. Jaideep Chaudhary sir? Yes, okay.
Yeah, good evening. Good evening. Yes,
yes, you want to
very
add
nice
something
discussion.
on this?
Yeah. Actually, nothing much to add what Dr. Pramod has told and the excellent presentations. Again, from IAP infectious disease chapter, we want to reiterate the rational antibiotic use and judicious use that we go on telling repeatedly. So that with this, I think we should go back and practice rational antibiotic use.
Yeah.
Yes, very true. And now I request Dr. Amol Pawar, sir, for the next session, the most important session. We are all here since 1 hour, 1.5 hours.
No,
So-
question answers. Any questions?
Actually,
Okay, any-
yeah. Question answers.
If any
the
questions are
chat
there.
box is full of the MMC registration numbers and IAP numbers.
It's difficult to, yes, it's difficult to find the
So,
questions from there. Yeah.
So question answer, only one thing I have seen is that is there a role of steroid in fever? Someone had asked meanwhile.
Any expert?
Role of, could you please repeat?
Role of steroids in fever, but that is very generalized question. They had not specifically asked.
Yeah, we should be very careful because number one, we have to exclude infection. Number two, there are specific indication of steroids even in infectious disease, like a tuberculous meningitis or certain other inflammatory conditions. So steroids should be reserved for very special situation, and it should not be, though steroid can bring down the temperature, but it should not be used to bring down the temperature. That will again suppress the underlying infection, if at all. So we have to be very cautious.
Yeah. Thank you, sir. I don't think there are any questions there in the chat box. So I would like Dr. Amol Pawar, sir, to have the vote of thanks.
Thank you, Renu ma'am. First of all, I thank all the speakers, Dr. Jayashree ma'am, Dr. Deepika ma'am, Dr. Neena Phade ma'am, Dr. Malvika, Dr. Ashutosh, Dr. Shushrita ma'am, for all the hard work done in preparing their topics with catchy messages for the general pediatricians. I also thank my dear friend, Dr. Jaideep Chaudhary sir, a stalwart CIP and at national level from West Bengal. He is a trainer of trainers in many modules of presidential action plans since many years. Sir is too busy in webinars and various CMEs and modules nowadays, but he immediately agreed to MAHAIP's call. I also thank dear Dr. Pramod Kulkarni sir, who in spite of his busy schedule, agreed to guide all the speakers and delegates on a topic near to his heart. I also thank Dr. Sanjay Iyer sir, Dr. Mewash Sheikh madam, who are the today's MMC observers, for their support in today's sessions. Because of their signatures and their support, all the delegates will be getting 2 MMC credit points free of cost. All the MAHAIPians, central IPians will get the MMC points free of cost. I thank today's moderators, Dr. Renu Poralkar ma'am, who is the chairperson of Women's Committee, and Dr. Pratibha Patil ma'am for coordinating between experts and speakers of today's session. I also thank all the delegates from YouTube and Zoom app also for their patient hearing, and we'll be eager to wait for all the delegates in next session. Thank you one and all. Next session will be on 3rd Tuesday of next month. Thank you, Renu. Over to you, Renu.
Yeah, next session will be on 17th May at the same time, 9 p.m. And there will be new topics and new judges and new speakers. And also, I would like to thank all of you for attending till the end, all the delegates today here. But not only for the MMC point, I think you have heard all the speakers also. So you should, I think they will also have taken back some knowledge from this CME. Yeah, and also it is an appeal by the Maharashtra IAP committee that you please subscribe to the YouTube MAHAIP channel, and so that you will get the all type of information, and all the topics are there till now present on that platform. Thank you so much.
Post session links will be